So ovarian tumors are a heterogeneous group of neoplasms. They are not homogeneous, they are not arising from a single cell type. They arise from the different cell types in ovary. So they are heterogeneous group of neoplasms. They may be benign, borderline or malignant, and understanding the benign, borderline or malignant status of the tumor, this influences the treatment of the tumor a lot. So there are three main types of cells from which the ovarian tumors originate. The first one is the surface epithelial cells. Embryologically, it is derived from the coelomic epithelium covering the ovary, and it gives rise to serous, mucinous, endometrioid, clear cell and Brenner tumors. And it is the most common group of ovarian tumors, and it consists about more than 95% of malignant ovarian tumors. The second type of cells are the germ cells. These germ cells are the precursors of oocytes, and these tumors include teratomas, Disgerminomas, Yolk tumors, choriocarcinomas. These tumors are more common in children and young women. The next type is sex cord-stromal tumors. These are derived from the ovarian stroma and the supporting cells present in the ovary. So these tumors include Granulosa cell tumor, Thecoma, Fibroma, Sertoli Leydig cell tumors. And these type of tumors, they are hormone secreting tumors. They may secrete estrogen or androgens. Like Granulosa cell tumor, they secrete estrogen. Leydig Sertoli cell tumor, they secrete androgen. So this is the basic histological structure of ovary. Here you can see the primordial follicle. It has a granulosa cell layer inside, and inside there is the primary oocyte, and there is a basement membrane outside. Then it becomes the primary follicle. Then there is the granulosa cell layer becomes one layer thick. Here is the primary oocyte inside, and then here appears the zona pellucida. And there is the mature or the secondary follicles. It has got 6 to 9 layers of granulosa cells. The primary oocyte is within, and there is the zona pellucida around the primary oocyte, and there is appearance of these theca cells. So this is the primary structure of the ovary, histological structure of the ovary. Now, as I told, there are surface epithelial cell tumors. These are the most common tumors. Then the germ cell tumors, then the sex cord-stromal tumors, and other tumors like metastasis. So in the epithelial cell tumors, the serous tumors, mucinous tumors, endometrioid, clear cell, Brenner's tumors. In the germ cell category, teratoma, Disgerminoma, and then choriocarcinoma, these all come under the germ cell tumors, and Thecoma, Fibroma, Sertoli Leydig cell tumors, Granulosa cell tumors, these all come under the sex cord-stromal tumors. And then the metastatic tumors to the ovary. Metastasis is rare, and it can come from various other tumors. So the WHO classification as per WHO 2020. The serous tumors include serous cystadenoma, borderline serous cyst tumor, low-grade serous carcinoma, and high-grade serous carcinoma. So the serous tumors may be serous cystadenoma, this is absolutely benign. Borderline serous tumor, this is borderline, and these are malignant carcinoma. The carcinoma may be low-grade serous carcinoma or high-grade serous carcinoma. Mucinous tumors, mucinous cystadenoma, it's benign. There is borderline mucinous tumor and mucinous carcinoma. Endometrioid tumor, endometrioid cystadenoma, benign, borderline endometrioid tumor, this is a borderline tumor, and endometrioid carcinoma. So every tumor has benign, borderline, and carcinoma, high grade carcinoma, these three types. Clear cell tumor, similarly clear cell cystadenoma, benign, borderline clear cell cyst tumor, clear cell tumor, and clear cell carcinoma. Brenner tumor, this also benign, borderline, and malignant. And other miscellaneous carcinomas, mesonephric like adenocarcinoma, undifferentiated or dedifferentiated carcinoma, carcinosarcoma, and mixed carcinoma. All these come under the epithelial tumors. Then the germ cell tumors. Germ cell tumors, first one is the teratoma. This teratoma may be mature, we call it dermoid cyst, and immature. Immature is the malignant one. And monodermal. Monodermal means struma ovary. You have heard about struma ovary. Here you will find the thyroid follicles and colloids. This struma ovary, ectopic thyroid. You will find thyroid tissue in this one and carcinoid. Then Disgerminoma, yolk sac tumors, embryonal carcinoma, non-gestational choriocarcinoma, and mixed germ cell tumors. The next is the sex cord-stromal tumors. This may be pure stromal tumors or pure sex cord tumors and mixed sex cord-stromal tumors. What are the pure stromal tumors? It arises from the supporting cells of the ovary. These are fibroma, thecoma, sclerosing stromal tumor, microcystic stromal tumor, Leydig cell tumor, steroid cell tumor, fibrosarcoma. These are purely arising from the supporting tissue. Pure sex cord tumors like adult granulosa cell tumor, juvenile granulosa cell tumor, Sertoli cell tumor, sex cord tumor with annular tubules. And mixed sex cord stromal tumors are Sertoli Leydig cell tumor, Sertoli Leydig cell tumors, and gynandroblastoma. And others are mesenchymal tumors like endometrioid stromal sarcoma, leiomyoma, leiomyosarcoma, myxoma, adenosarcoma. These are all rare tumors, but they can occur in ovary. Mixed epithelial and mesenchymal tumors are adenosarcoma, carcinosarcoma. Metastatic tumors, Krukenberg tumor. Krukenberg tumor may come as a short note. It mostly arises from the gastric carcinoma. It is bilateral and the ovary is enlarged, but the shape of the ovary remains unchanged. This metastasis occurs mostly from gastric carcinoma. Krukenberg tumor. Then metastasis can occur from breast, colon, and other primaries. And there are some rare tumors like small cell carcinoma, Wilms tumor, or solid pseudopapillary tumor. These are rare types of tumor. Same thing is written here. Here the molecular mutations are given. If you can remember, it is fine. Otherwise, just go through the chart once. So, what are the symptoms? What will the patient present with? The most common symptom is abdominal distension and pain. And then there will be, in a later stage, there will be bladder and bowel disturbances, weight loss, and you will find adnexal mass. On examination, you will find an adnexal mass. There may be ascites and there may be cancer cachexia. Investigations of choice, you will do an ultrasound, and with the ultrasound you can find solid or cystic nature of the tumor, the septations if present. CT or MRI, you do it for staging. Tumor markers, CA125, AFP, LDH, beta HCG. These are the tumor markers for ovarian tumor. Serum tumor markers, you will see increased amount of these products in the serum. and always histopathology followed by IHC is the gold standard of diagnosis. Now a few lines about all the common types of tumors. Serous tumors are the most common epithelial tumor, benign, borderline or malignant, and the malignant forms may be bilateral and associated with ascites. Mucinous tumors are larger than the serous tumors, and the cysts are multiloculated. Whereas in the serous tumors, it will be uniloculated. And the fluid in the serous tumors will be clear watery fluid, and in the mucinous tumors, the fluid will be rich in mucin. It will be a mucoid fluid. It also may be benign, borderline malignant, and in this tumor, mucinous tumor, there is risk of pseudomyxoma peritonei if the tumor ruptures. Carcinoma, it is malignant epithelial tumor. It resembles the endometrial carcinoma. It looks same like the endometrial carcinoma of the uterus, and it is often associated with endometriosis. Clear cell carcinoma, this is an aggressive kind of epithelial tumor. It is also associated with endometriosis, and it has a poor prognosis. Brenner tumors are rare and they contain transitional type of epithelium, usually benign, maybe borderline or malignant. Mature teratoma or the dermoid cyst. It is the most common benign germ cell tumor. It contains tissues from all the three germ layers. It can contain hair, teeth, bone, intestinal mucosa, everything. Immature teratoma, it is a malignant germ cell tumor, and here you will find embryonic tissue components. So when you examine a teratoma, you have to search for these embryonic tissue components to say whether it is a mature teratoma or an immature teratoma. Disgerminoma, it is the most common malignant germ cell tumor, and it is associated with elevated LDH, and it is the most radiosensitive ovarian tumor. Its primary treatment is radiotherapy. Yolk sac tumor are also highly malignant germ cell tumors. It produces AFP. I told you about the tumor markers. LDH for Disgerminoma, alpha fetoprotein for Yolk sac tumor. And histologically you will find this characteristic Schiller-Duval body. Granulosa cell tumor, these are sex cord-stromal tumors. They secrete estrogen. They will cause hyperestrogenemia, and it will cause endometrial hyperplasia or endometrial carcinoma due to raised estrogen level, endometrial hyperplasia or carcinoma. Sertoli-Leydig cell tumor, this produces androgens, and this will cause virilization in female. Fibroma, it is also a benign stromal tumor, but it is associated with a syndrome called Meigs syndrome. Meigs syndrome is fibroma with ascites with pleural effusion. This is important. Meigs syndrome, this may come as MCQ also, and this may be asked in the Viva also. Meigs syndrome consists of fibroma, ascites and pleural effusion. These are the triad of Meigs syndrome. So, this is in a chart form. Serous tumors, these arise from the epithelium, mucinous from the epithelium, endometrioid from the epithelium, clear cell from the epithelium, teratoma from the germ cells, disgerminoma from the germ cells, yolk sac from the germ cells, granulosa, Sertoli-Leydig cell, fibroma from the stromal cells. And their common associations, serous, mucinous, they may be bilateral. Serous is the most common type of ovarian tumor. Endometrioid tumor may be associated with endometriosis. Clear cell has a very poor prognosis and it is a very aggressive tumor. Teratoma, you may find hair, teeth, bone inside the cyst. Disgerminoma, LDH is the marker. Yolk sac tumor, AFP is the marker. Granulosa cell tumor, hyperestrogenism. Sertoli-Leydig cell tumor, androgen secretion and virilization, and fibroma associated with Meigs syndrome. So, what is the gross pathology? How will it look on gross? Serous cyst adenoma, it will be unilocular cyst, thin walled and will contain clear fluid. Mucinous cyst adenoma, it will be a large multiloculated cysts and it will be filled with mucinous fluids. Teratoma, it will be a cystic mass also and there will be a region where there will be tuft of hair, teeth, sebaceous material and it will be filled with sebaceous material. In fact, when you cut a teratoma, the first thing you will see is the sebaceous material. And fibroma, it is a solid, firm and white mass. It will look like that. So, here is the serous cyst adenoma, a single thin-walled uniloculated cyst. This is a serous cyst adenoma. In mucinous cyst adenoma, you can see there are multiple locules, multiloculated cyst. There are the locules. Here is one, here is one, here is one, in between. So, it is a multiloculated cyst. This is the teratoma. You can see this space, you can see these hairs and here you can find bone, teeth and all those things. And in this lining you can find all, if it is an immature teratoma, in this lining you can find some embryonal components also. This is a ovarian fibroma and on the cut surface it will look like this, solid, firm, white, lobulated structure. So, these are the gross findings of the important ovarian tumors. Next, microscopically, what will you see? In serous carcinoma, you might see papillary structures on the lining and psammoma bodies. You can find psammoma bodies in very few tumors. One is serous carcinoma, the other ones are thyroid, papillary carcinoma of thyroid, psammomatous meningioma. There you will find psammoma bodies. So, it is one of the tumors where you will find psammoma bodies. Mucinous cell carcinoma will have tall columnar cells with mucin and there will be stratification of the epithelium. Here in serous carcinoma, the epithelium will be a single lined epithelium and the epithelium will be more or less cuboidal. Disgerminoma, there will be sheets of large cells with clear cytoplasm, central nuclei, fibrous septa and within the fibrous septa there will be presence of lymphocytes. Schiller-Duval bodies are characteristic of Yolk sac tumor and Karl-Exner bodies, they are characteristic of Granulosa cell tumor. So, see, Schiller-Duval bodies are like glomerular structures. It looks like glomerulus. And Karl-Exner bodies, it will look like small follicle-like spaces. So, this is a serous carcinoma. You can see it is a high-grade carcinoma. You can see the cells. The cells are more or less cuboidal, but there are at some places there are papillary structures like this. So, this is a high grade serous carcinoma. This is a mature cystic teratoma. You can see the squamous lining. You can see the hair roots and sebaceous glands here. Here is the keratin. You can see the keratin. You can see the keratin here also. And there you can, in the stroma, you cannot find any immature components. So, this is a mature teratoma. This is Yolk sac tumor and these glomerular structures. What are the modes of spread of ovarian tumor? It can spread directly, extend to the uterus, fallopian tubes, contralateral ovary, bladder, rectum, and it is more common in case of epithelial tumors. So, there is direct spread to the adjacent structures, uterus, fallopian tubes, contralateral ovary, bladder, rectum. There is seeding of the peritoneal surfaces causing ascites, omental caking and peritoneal nodules. It is classic in serous carcinoma. Lymphatic spread, the ovary drains into paraaortic lymph nodes and these are the most commonly involved lymph nodes, and this lymphatic involvement is important for staging. And hematogenous spread, it is less common, but metastasis can occur in liver, lungs, bone and brain. These are always the common sites of metastasis: liver, lungs, bone and brain. So this is the diagram. There is peritoneal, this is peritoneal metastasis, this is hematogenous metastasis, liver, brain from the ovary via the bloodstream. It may also nerve related metastasis. The primary ovarian tumor can also involve the nerves, and it is the lymphatic. The primary lymphatics to be involved are the paraortic lymph nodes. So this is the mode of spread of ovarian tumor. So this is the chart: direct metastasis to uterus, tubes, bladder, rectum, and a typical tumor association is epithelial tumors, transcoelomic spread, peritoneum, omentum, and it may cause ascites also. These are common with serous carcinoma. Lymphatic spread to pelvic and paraortic lymph nodes. It can occur with any kind of malignant epithelial tumors. Hematogenous spread in advanced stages of any kind of ovarian carcinoma. Lung, liver, bone and brain may be affected. And implantation. Implantation may occur in peritoneal surfaces and scars, and this implantation may give rise to post-surgical recurrences. Now, what are the complications of the ovarian tumors? There may be local complication, there may be systemic complications, treatment related complications, and another thing is paraneoplastic syndromes. So, local complication may be torsion. Torsion will cause acute abdominal pain, ischemia, and necrosis of the ovary. Rupture may cause hemoperitoneum with serous or mucinous cyst. Chemical peritonitis with dermoid cyst. When the keratin spills into the peritoneum, it will cause mucinous cyst adenomas. You can get that pseudomyxoma peritonei. There may be obstruction of the bladder, ureter and rectum. There may be urinary retention, constipation, and ascites. Ascites is especially common with malignant epithelial tumors. Systemic complications, metastasis like peritoneal seeding, lymphatic spread, hematogenous spread, paraneoplastic syndromes. Estrogen excess. Granulosa cell tumor causes estrogen excess leading to endometrial hyperplasia or endometrial carcinoma. Androgen excess. It occurs with Sertoli Leydig cell tumors and it causes virilization. Hypercalcemia may occur with small cell carcinoma of the ovary. And cachexia, it occurs in every cancer in an advanced stage. And treatment related complications may be the surgical risks like bleeding, infection, adhesion. Chemotherapy, it has its own side effects like nephrotoxicity, neurotoxicity, myelosuppression, rather bone marrow suppression, and then loss of fertility. So, these are the complications of ovarian tumor. Now, this is the summary table. Torsion of the ovary is more common with dermoid cyst and cyst adenoma. It is more common. Dermoid cyst, in fact, it is most common with dermoid cyst, and it may also occur with the cyst adenomas. Rupture is more common with mucinous cyst adenoma and causes pseudomyxoma peritonei. Ascites is more common with serous carcinoma. Hormonal effects, granulosa cell tumor produce estrogen and Sertoli Leydig cell tumor produce androgen. Metastasis, Krukenberg's tumor or peritoneal implants, and paraneoplastic syndrome most common with small cell carcinoma which causes hypercalcemia. Now, these high points, these may come as MCQs. Most common ovarian tumor overall. Overall, the most common ovarian tumor is serous cyst adenoma. Serous cyst adenoma, the benign form. Most common malignant ovarian tumor is serous cyst adenocarcinoma. This is the benign form is the most common overall ovarian tumor, and the most common malignant ovarian tumor is serous cyst adenocarcinoma. Most common benign germ cell tumor is a mature teratoma or dermoid cyst. Most common malignant germ cell tumor is the Disgerminoma. Tumor associated with estrogen secretion is Granulosa cell tumor, and Meigs syndrome. It is a triad of ovarian fibroma, ascites and pleural effusion. So these things can come as MCQs or may be asked in your Viva. So these are the high yield points.